All of you. Today we have our speaker. Her name is Dr. Nikita Patel. She is from CM Patel College of Physiotherapy. She is assistant professor and MPT in pediatrics. Madam, thank you so much. In very short period of time, you have accepted our invitation, and it is over to you. Ma'am, you can start.
Thank you so much, ma'am, for inviting me. I am Dr. Nikita Patel, Assistant Professor at CM Patel College of Physiotherapy. Today, I will learn you regarding the evidence-based physiotherapeutic approaches in the cerebral palsy. So first, let's we see the introduction. So it is a very short introduction. Cerebral palsy is a group of permanent disorders of development of movement and posture causing activity limitations attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. So up to 1 year, that insult can be occurred. So it results in a cerebral palsy. Incidence of the CP is up to 3 cases per thousand live birth in India. Prevalence is 1,000 children per 1,000 children. That is a 2.95. In the past years, CP was known as a Little's disease on the name of the English physician Sir Francis William Littles, and he had described the first time CP. So, because of his name, the this CP can be diagnosed as a Little's disease in the past. These are the very known causes of the cerebral palsy. Prenatally, that is a torch infection, then inflammation of the placenta, RH incompatibility, that means if mother is negative and fetus is positive, so RH incompatibility can be occurred. Diabetes during pregnancy, so that is a gestational diabetes, genetic causes, exposure to the radiation, and maternal jaundice. In the perinatal causes, that is a premature intraventricular hemorrhage, birth asphyxia, babies aspirated the meconium. So meconium aspiration can be occurred. Birth trauma, breech delivery, and low birth weight. That is less than 2.5 kg weight is there. So these all are known as a low birth weight. That is a criteria for the very low birth weight is a 1.5 to 2.5, and less than 1.5 is known as a very low birth weight. So if less than 2.5 birth weight is there, so it results in, sometimes it results in cerebral palsy, but not every time. Coagulopathy, and in the postnatal brain damage secondary to cerebral hemorrhage, trauma, infection or anoxia, motor vehicle accident, shaken baby syndrome, lead exposure during after pregnancy to the baby, meningitis, encephalitis, connectitis, that is a hyperbilirubinemia, and methyl mercury exposure. So these all are causes for the cerebral palsy. These are the types of the cerebral palsy. So these are the everyone knows regarding all these types, but I will just tell about one thing, that how to write the diagnosis for the cerebral palsy. So I will just one give you one example. If a 5 years old baby having the spasticity to the lower extremity, both lower extremity, and they can walk indoor, that means in the house, so that diagnosis you have to write down, that is a spastic diaplegic cerebral palsy level 2 for GMFCS scale. So you have to write down in this way this diagnosis. So topographical distribution according, these are the five classification. In the depending on the tone and movement patterns, these are the five. And according to GMFCS level, there are the five levels are there. So these are, but you have to write in this way. I told that thing. Now most question for the everyone, that how to differentiate that various types of cerebral palsy. We know that patient came to us that we can say that is just cerebral palsy, but later on differentiation is very difficult, that patient is hypotonicity is there, hypertonic CP or atheter CP. Okay, so these are the differentiation mainly. So we can see this differentiation, that how to differentiate between this cerebral palsy. So first characteristics for the hypertonicity, that everyone know regarding this, tone is low. That is a low tone, floppy child. In the hypertonicity, that is a tone is high and spastic, stiff and rigid. Atheter CP, it is a fluctuating tone, writhing and constantly moving. Okay, so it is the atheter CP. This is the discrimination. Distribution, whenever we are talking about the hypotonicity, so it is the generalized tone is hypotonic, and this is the symmetrical. In the both side you can see hypertonicity, it is generalized, the tone is generalized, that is the tone is increasing, but it is asymmetrical. In the athetod CP, it is a generalized, but it can be asymmetrical. That is a not discriminate. That is a symmetrical or asymmetrical. Both can be happen in the athetod CP. In the DTR, there is a deep tendon reflex. In the hypotonic CP, it is a weak. In the hypertonic CT, it is abnormally strong. So we can say that is a brisk or clonus can be happen in the hypertonic CP and athetod CP. Achievement of the motor milestone, so it the achievement of this what motor milestone is delayed, and it is depends on the hypotonicity. If tone is reducing more, that is more hypotonicity is there, so it milestone achievement for the child is a later on, it is a delayed. In the hypertonicity same, it is delayed, but it depends on the tone. And in the athetod CP is also delayed, but it depends on the severity of the tone deviation. Influence of the body position, so tone remains same in the hypertonicity. In the hypertonicity, what happens, this tone is fluctuating with the changes in the body position. In the athetod CP, that is a tone is fluctuating with the change in the body position. Next is the consistency of the muscle. So it is a soft and duffy. In the hypertonicity, you can see. In the hypertonicity, hypertonic CP, you can see the hard and rock-like consistency of this muscle. And in the athetod, you can see stringy and elastic. In the respiratory problems, you can see in the hypertonic CP that is a shallow breathing, choking that occurs because of this weakness in the pharyngeal muscles. Hypertonicity can be occur because of the thoracic mobility and limited inspiration and expiration. And in the athetod CP, reducing thoracic mobility and shallow breathing is there. In the speech problem, because of this shallow breathing, there is a difficulty with sustaining voice sound, so patient cannot sustain his speech for a longer period of time. In the hypertonic CP and athetod CP, you can see the dysarthria. Feeding problems, so in the which type of feeding problems, so in the hypertonic CP, it is a weak gag reflex, and sometimes it is the absent. In the hypertonic CP and athetod CP, you can see abnormally strong gag reflex is there. That is abnormally that is a brisk gag reflex you can see. Now we are talking towards the physiotherapeutic management. So in the physiotherapeutic management, there are various approaches you can use for the cerebral palsy to treat the cerebral palsy child. So according to symptoms and according to impairments, you have to decide by yourself that which approach is appropriate for the particular child. Okay, so these are the various approaches are there: muscle education and braces, progressive pattern movements, synergistic movement pattern, PNF, NDT, Vita approach, conductive education, sensory integration, task oriented approach, hippotherapy, hydrotherapy, robot therapy, then suit therapy. These all approaches you can use to treat the cerebral palsy child. Now we will see one by one all these approaches. First is muscle education and process. First, muscle education. So, W.M. Phelps, an orthopedic surgeon in Baltimore, was one of the pioneers in the treatment of cerebral palsy, who encouraged physiotherapists, occupational therapists, and speech therapists to form themselves into the cerebral palsy rehab team. So, he was the first that who make this CP rehab team. 15 modalities were described, and specific combination of these modalities were used for the specific type of cerebral palsy. So whenever the patient came to us, so we are giving these all treatment, these all the modalities, that means all the methods are that. We are not talking here that modalities, that means electrical modalities, but methods, that is a movement. So which type of movement we can use for the particular time, particular movements. So we can use massage. If hypotonicity is there, so we can give the massage. We can give the passive movements for both the condition, hyper or hypotonicity. We can give active assisted movement if movement is not properly done by the patient, so we can do the active assisted movements. Active movement, we can give the resisted movement to improve the strengthening. We can use conditioned movement. We can use the confused and combined movement, that is a synergy pattern. If patient is not having any of the movement, so we can use the combined movement. Next, we can give the relaxation technique. Next, we can give the movement from relaxation. We can give the rest. We can give the reciprocation. We can give the balance training. We can give reach, grasp, and release. It is for the fine motor grip. So we can give reaching, grasping, and releasing. These all activities we can do for the fine motor to improve the fine motor grip. We can give the skills of the daily living, that is the ADL activities. So we can improve the ADL activities through this. We can give braces and caliper for the needy patient. That means if someone having the not a problems with the lower extremity control, so we can advise for the AFO, KFO. So according to that the condition, we can prescribe the orthosis, and because of this orthosis we can prescribe, we can do the further treatment for that particular patient. So it will helpful to for us. So WM Phelps given this muscle education and process approach. Next is the synergistic movement pattern. It is given by the Brunstrom. I think everyone know regarding this approach, Brunstrom approach. He was the physical therapist who worked with the adult hemiplegia and assessed the stages of recovery and compared them with the normal sequential neuromotor development in early childhood. That means it not only and only using for the adult patients, that is stroke patient, but sometimes we can use in the pediatric patient also this Brainstorm approach. And there are mainly features are there. So first is the reflex responses. So we can use these reflexes for the treatment purposes. That means if we are initiating this response reflexes, so we can get the synergy pattern and in the initial stage. But if synergy pattern we can get, then our role is to break the synergy. And if we are breaking the synergy, then and then we can get this voluntarily function of the particular muscles. Next is the associated reaction are used as well as the hand reaction. For example, that is the upper extremity spasticity is more. Okay, so we are giving just hyperextension of the thumb. So whenever we are giving the hyperextension of the thumb, so we can get the relaxation of the finger flexors. So we can get the full hand opening. We are hyperextension of thumb is that. So we break the synergy pattern and then we can get the finger flexor relaxations are there. Okay. Resisted action was used on the unaffected side to activate the affected side. So sometimes we can give resisted if right side is affected, so we can give the resisted exercise to the left side. So if left side we can give the resisted movement. So because of this left side, that is a associated reaction you can see on the affected side. That means right side you can see the movement. So this is the associated reaction we can use as a treatment purpose in the synergistic movement pattern, that is the Brainstorm approach. The training of patients voluntarily control is developed later in the therapy program. So it is the one of the evidence. Christina Treadwell done study on 12 children with diaplegic CP and given Brainstorm approach for 3 months and concluded that children with CP show lower extremity muscles were voluntarily activated and greater understanding of muscle recruitment patterns under a variety of tasks may provide new direction for the motor control retraining or other forms of intervention. So it is one of the helpful treatment brainstorm approach for the cerebral palsy child. Next is the progressive pattern movements. It was given by the Temple Fay, and sometimes this approach is known as a Temple Fay approach. He was a neurosurgeon in Philadelphia and recommended that cerebral palsy be taught motion according to its development in the evolution, following the Dorman-Delgado system. So he regarded that ontogenetic development as a recapitulation of the phylogenetic development. So first you know regarding the what is the ontogenetic development. So what is the ontogenetic development? So in the ontogenetic development, that we can say that is the development from the in the worm, that is a embryo, that is from the fertilization of the eggs to the adult movement, adult person. It is a transition from the fertilization eggs to the adult person. It is called the ontogenetic development. And in the phylogenetic development, that is the evolution of the species. That means we can say that mammalian body, then we can say from the transition to the humans. Okay, so this type of transition is called the evolution of the species, that called the phylogenetic development. Based on these ideas, he developed progressive pattern movement, which consists of the 5 stages. So first one is the prone line. So you can see that is the prone line, first stage. In this, whenever we are using this progressive pattern therapy, we need 3 person. So first person is controlling the head movement, second person is controlling the upper extremity, and third person is controlling the lower extremity. So in the first stage, in the prone lying, just we have to move the head movement, that is rotating the head. Just you have to just rotate the head to the right side, and later on you have to rotate the head to the left side. It is only first stage. In the second stage, it is the homolateral stage. So if you are rotating the head to the right side, so in the face of the right side is there. So upper extremity, you can see in this image, the upper extremity of this face side is flexion, in the flexion, and in the skull side, this upper and lower extremity is going into the extension. Third stage is the there is a contralateral stage. So in the contralateral stage, what happened, contralateral stage is a primary stage of, we can say, the crawling position or creeping. So ultimately that is a contralateral stage is, we can say, the creeping. So in the creeping, what happened, the face is in the face side, upper extremity is in the flexion, but lower extremity is going into the extension. So it is the somewhat the opposite than the homolateral stage. In the fourth stage, we can say the crawling. You can see in this image, it is the crawling. And fifth stage is the walking. So these are the five stages of the progressive pattern therapy. The progressive pattern movements called the patterning therapy, for the first practiced by the passively at least 5 times a daily. This approach restricts itself to prone development and expects demanding in daily regimes of the treatment, amounting to 8 to 10 hours a day, 7 days a week in many cases. It is the evidence is there, that is a Nurkish done study on a 15-month-old male child presented with inability to sit independently corresponding to this age. That means in the 15 months of the age, that is a sitting is developed, right? So here, that is a 15 months old male not achieve the sitting independently. But the child was assessed through the MAS and GMFCS scale, and he was given a progressive movement pattern therapy for 45 minutes each day for 5 days a week for 45 days, and found improvement on a MAS and GMFCS both. So you can see that is a spasticity can be reducing through this progressive pattern movement therapy, and in the GMFCS scale, you can level can be improved. Next one is a proprioceptive neuromuscular facilitation. It is the technique. Everyone knows regarding this PNF technique, I think. It was given by the Herman Kabat, of neurophysiologist and psychiatrist in the United States, and has discussed various neurophysiological mechanisms which could be used in a therapeutic exercise. And the main features of this method are the use of the following. That means the main features are that there is a spiral, rotational, and diagonal movement. So in the rotational and diagonal movement, you can see in the functional activities like dressing, walking, playing tennis, golf, or football. So all these functional activities need this diagonal pattern. So if we are using these all activities as a treatment purpose, so ultimately we can improve the activity for daily living, as well as we can break the synergy pattern. So these are the special techniques: repeated contraction, slow reversal, rhythmic stabilization, hold, relax, and rhythmic initiation. It is the, you can see in this image, it is the upper extremity PNF technique we can use in this way. And here you can see that is a lower extremity PNF pattern you can use for this particular child. For a This child is independent, but if patient is not standing properly, so you can grasp from the pelvis, and you can advise that just put your leg here, that is a diagonal pattern can be occurred. And just back, you can say that is a put your leg here, that means it is a diagonal pattern can be activated. So ultimately you are giving the PNF technique. Gorikal study included 22 hemiplegic cerebral palsy children which given PNF and conventional therapy in lower extremity. This study suggests that PNF have an effect on selective motor control of lower extremity in children with hemiplegic cerebral palsy. Kovala Rakesh K found that 19 years old boy with spastic diaplegia given PNF techniques, mainly rhythmic stabilization and dynamic reversals, were given for 12 weeks. Work balance scale and gait parameters were taken before beginning of the study and after completion of the 8 weeks, and there were significant changes in work balance scale and gait parameters found after the therapy. So balance can be improved, and as well as there is a gait is also improved after giving this PNF techniques. NDT, that is a Bobath approach. Carl Bobath, a neuropsychiatrist, and Berta Bobath, a physiotherapist, based assessment and treatment on the premises that the fundamental difficulty in cerebral palsy is lack of inhibition of the reflex patterns of posture and movement. So mainly Bobath is working on the posture and movement. That's it. The Bobaths associated these abnormal patterns with abnormal tone due to overaction of the tonic reflex activities. So if Bobath is telling like that, if abnormal tone is there, so ultimately if abnormal tone is there, so that is you are never get the normal patterns. So you have to reducing the, or you have to normalize the tone, and so you can, if normalize the tone, so ultimately you can get the normal pattern. So because of this abnormal tone is there, so ultimately there is a primitive reflexes, these tonic reflexes you can get in the child. So these tonic reflexes such as the tonic labyrinthine reflexes, symmetrical tonic necrol, that is STNR, ATNR, have to be inhibited in order to counteract the abnormal patterns of released postural reflex activity, and at the same time you have to facilitate the normal reaction by the spatial techniques of handling. So if any one of the baby having the ATNR reflex and STNR reflex, so you just have to break this ATNR and STNR reflexes. You have to inhibit the ATNR and STNR reflexes. So ultimately you can, there is a normalizing this tone, and just you have to facilitate, you have to inhibit this abnormal reflexes, and you have to facilitate the normal reactions in the through the Bobath approach. There are many Boba trained physiotherapists who first spend time on reducing abdominal tone so that the child is prepared for a movement. Preparation involves, so which type of preparation you can give before starting this Boba approach? So you can give the stretching, handling, positioning by the therapist to improve quality of tone and therefore the movement. Key points of control are used by many therapists to change the patterns of spasticity so that the child is prepared for the movement and correct posture. The key points are usually head and neck, shoulder, pelvic girdles, as well as use of the distal key points to aim at the normalized abnormal tone. So you can use all these key points to normalize the abnormal tone. You can see in this image, first one is there is a abnormality of the, like scissoring gait is there, so it is ultimately abnormality. So you just have to reducing this scissoring pattern, so you can use this approach. Here that is if you are activating this trunk extensors muscles and neck extensor muscles through this activity, you can facilitate the abdominals, that is the internal obliques and external oblique muscles through this activity. And here that is a diagonal rotations you can go through, and ultimately that is a improvement. And in this image you can see that is a uh, uh, flexors and extensors muscles are activating through this. So one of the evidence for this, it is a Shamsodini Alariza done study on 22 spastic cerebral palsy children and given NDT and SIT for 3 weeks, and concluded that NDT and SIT improved gross motor function children with cerebral palsy in 4 domains. So in the GMFM there is 4 domains are there: lying, rolling, sitting, crawling, and kneeling and standing. So you can see improvement in all or the 4 domains. Munhi included 10 children with spastic diaplegia and divided into 2 groups, task oriented approach and NDT, and they received treatment for 5 times a week for 6 weeks, and concluded that task oriented training and NDT for muscle vitalization both improved the sitting posture of children with cerebral palsy. Next one is the Voita approach. Sometimes Voita approach is known as a reflex gripping and reflex rolling approach. So Vaclav Voita, a neurologist working in a Caesarclavian in Germany, developed his approach from the works of the Temple Fay and Kabat. Okay, after this Temple Fay and Kabat approach, that is a progressive pattern therapy and PNF approach, after this Voita approach can be discovered, and this approach combines the reflex gripping and reflex rolling. So in this Voita approach, what happened? They are That's Vita is told about this. If you are stimulating some of the points that are trigger points are there, they told that is a reflex zones. Trigger points in the bodies are there. So if you are targeting that particular points, then and then you can get the response. So if these trigger points are called, he called that is a reflex zones. So if you are activating this reflex zones, so ultimately you can get the movement. So here you can see these all are the reflex zones. Uh, these all are reflexes zone. So first we are talking about the reflex creeping. So creeping pattern involving the head, trunk and limbs are facilitated at various trigger points or reflex zones. So you can see all these are reflexes zone. And the creeping involves active muscle responses, the appropriate triggering from these zones with the sensory stimuli, and you can get the response. So there are 9 zones for the reflex triggering for the reflex locomotions. Next is the reflex rolling. So here in the same way, there is a sensory stimulation if you are giving through the touch, pressure and stretch. So then and then you can get the response. And second one, you have to give the resistance. So it is the phase 1 for the reflex rolling. So here you can see in the phase 1, you have to stimulate through either touch or pressure or stretch, whatever. But you just have to stimulate this these points, this zone, and you have to resist from here. You have to resist in the opposite side. So ultimately you can get the reflex, that is baby is going from the reflexly supine to side. Then phase 2 is starting. So in the phase 2 you just have to, you can see the scapula, and the second is the ASIS, and you just have to stimulate here. And then it is going from the side lying to baby goes into the prone position. So in the reflex rolling there are the two phases are there. So, evidence for this is a Soon Young Ha conducted a study on the 10 children with spastic CP were randomly assigned to a general physiotherapy group and a Vita approach group. Interventions were implemented for 30 minutes per time, 3 times a week for total of 6 weeks. Vita approach may be presented as an effective treatment method for improving sitting position and diaphragm movement during the inspiration in children with the spastic CP. Next is a Jung von Lim conducted a study on 3 spastic diaplegic cerebral palsy and given a Vita approach for 8 weeks. The study indicates that Vita therapy can do a good role in improvement of the spatiotemporal gait parameters of children with spastic diaplegic CP. So it is the using for the Vita approach for this particular child. Next is the conductive education approach. So Andras Pito in Budapest in Hungary originated conductive education. After Professor Pito's death, the work was continued by the Dr. M. Hari until her death. The main feature is the integration of the therapy and education by having the following. So Andras Pito is believing in that not only a one person is treating the patient or particularly CP child, but uh, there is a one conductor is there. So you have to gather 50 to 20 persons with cerebral palsy child, you have to gather in a one place, and then you have to treat them, and their fixed schedule is there for that particular that's 50 to 20 persons group. That is a whenever they are getting up they have to do the brush, so all the ideal activities, and then after there is a therapy timing is there, then there is a lunch time, dinner time, everything is scheduled. And also sleeping time, study time, everything is scheduled is there. And they have to follow that particular schedule for a particular timing, that is a 9 to 10 is there for the lunch time. So 9 to 10 breakfast time, so 9 to 10 is a breakfast time is there fixed. So you have to follow this fixed schedule for a particular child. uh, a conductor, so that organizing a conductor, so conductor acting as a mother, nurse, teacher and therapist. She is specially trained in a rehabilitation of motor disabled children in a 4-year course. There is a 4 years course to become a conductor. She may have one or two assistants, and the group of children is about 15 to 20, and they have to work together. You can see in this image that is a sitting. So sitting activities is particularly it is the prayer time is there. So every child is gathered in a line, and they are doing the prayer. Here, that is the activity, it is the physiotherapy activity timing. So everyone is doing activity with the ring. So every task is similar is going on. Here is the storytelling time. You can see here this child is gathered here and they are telling the story. And it is the walking time. You can see all these having the walker. So it is the walking time that is in the part of the therapy time. And it is the walking, but everyone is walking together. So it is the conductive education uh, sa- uh, uh, approach. And in the mainly basically why conductive education approach is developed. So it is through the conductive education approach that is a socialization of this child is improved. It is a very important thing. So here there is a fixed timetable is there, and you have to just follow this timetable. It is the evidence is that Hamid Dalvan done study on 45 children of the spastic CP to compare the Bobat technique, conductive education, and education to the parents, improved ADL skills in children with cerebral palsy. In the conductive education approach, group education promoted better social communication and more mobility in familiar environments. On the other hand, practical education and treatment programs improved ADL skills. So mainly there is a social communication and ADL activities or ADL skills can be improved through this conductive education. Rainer Blank performed study on 64 children with CP and compared the effect of the task-oriented training and conductive education and improved the coordinative hand functions and ADLs in children with CP, and there was no effect on the elementary of the hand function, and concluded that improved coordinative hand functions and ADLs in children with CP. So they are concluding that there is a no role of the hand function particularly, but that ADL activities can be improved through the conductive education approach. Next is the sensory integration approach. So sensory integration approach was devised by the Jean Ayers in 1979. Occupational therapists may use this approach for children with clumsy motor skills or developmental incoordination syndrome or perceptual motor disorders. It has been used in other conditions as well as in CP. Children with CP may also have perceptual or sensory processing difficulties which need to be assessed, and you can treat. Stimulation of all these senses, there are seven senses is there in the body, and just you have to stimulate all the senses to get the better improvement. So all these senses are stimulating is provided in learning motor control with active motor function. Sensory integration has enjoyable motor activities which can be selected and added to the physiotherapist electric approach. A physiotherapist and occupational therapist may overlap their work. So if any one of the person who having the sensory deficits or sensory processing disorders are there, so they are working with the sensory integration therapy. And this therapy is given by physiotherapist as well as the occupational therapist both. Here it is the everyday sensory integration. How you can give the everyday sensory integration? If some of the person are not coming for the therapy regularly, so how can you advise for the sensory integration therapy? So first we can advise for the trampoline. So jump, run, roll on the trampoline. So vestibular activation is there. Next is that is a carrying the groceries or anything else. That means carrying anything weighted. That is a waiting chopping bag. Okay, so because of that there is a proprioceptions can be activated. Next there is a relax and unwind in a bath, that is just bathing. So and there is a add one epsom one spoon epsom salt you have to add in this water, so it easy the stress. Next is the using, you can use the straw. So because of this there is oral relaxation you can get, because oral muscles are working properly, so oral relaxation can be get. Here it is the focusing on the breathing, so it get the relaxation, and they get the relaxation. Listening of the music is another, and because of this listening the music you can get the relaxation more. Next is for the autistic child and who having the hyperactivity, so you can advise for the running, walking, swinging, ride, scooting and skating. So because of that there is a sensation of this vestibular proprioceptors all are activated, or if all are activated and all are working properly. Next you can advise for this plate of paint, drawing, so their tactile sensations are improving through this drawing and plate of and painting. working. So this tactile and proprioception workings are properly through this. So all these are, you can advise all this activity for the sensory integration at home. So it is called the everyday sensory integration. These are the sensory integration therapy, and you can see here it is the proprioceptions can be working. Here you can see there is a swing is there, and there is a balls are there, so you can improve. Here you can improve tactile, then vestibular as well as proprioceptions feedback you can give through this activity. And here you can give, that is a vestibular activation, you can activate the vestibular system here with this activity. And also as well as with this vestibular activation, you can activate this coordination activity here. So this is very important sensory integration therapy for children who are having the sensory processing disorders. So Dr. Pooja Kumari conducted a study on the 30 children with the cerebral palsy were included and given the sensory integration therapy and conventional therapy for a 5 days a week for 6 months, and found the effect of the sensory integration therapy to be more effective and more powerful in improvement in the GMFM among the children with CP. Mohammad Sayed done study on 30 hemiplegic cerebral palsy and given sensory integration along with the conventional physical therapy program for 3 months lead to statistically significant difference in the gait parameters among the children with the hemiplegic cerebral palsy. Sometimes what here, that is, the gait parameters can be improved, because sometimes what happen, we are thinking about that patient's strength is good, patient's tone is almost normal, but patient is not walking properly. Why? Because of sometimes what happened, that vestibular system and proprioceptive system is not working properly. So if you are working on this proprioceptive system and vestibular system, so definitely you can get the result. So in this way, that is a sensory integration therapy is a very important part for these cerebral palsy children. Next is the task oriented approach. So, these approach is proposed by the Shamway, Cook, and Walcott for the assessment and training of the posture and movement in people with the neurological disabilities and motor problems, mostly in the elderly population and for the stroke patients. So, it is not only for the stroke, but for the cerebral palsy, some of the evidences are there. So, you can improve the balance with this task oriented approach in the children with the cerebral palsy. So, which are the main aspects for these approaches? So, first is the constraint on a motor task. So, it is hypothesized that you have to just constrain on a particular motor task. Second one is the person's interaction with the relevant features of the environment in which the task is performing. Third one is the motor learning strategies. You have to just learn particularly for a particular task. And fourth one is the augmented feedback. Feedback is a very necessary thing for this task oriented approach. So constrain the motor task, then relevant interaction with the relevant features to the environment. Third one is the motor learning strategies, and fourth is the augmented feedback. So these four are the main important for the task oriented approach. Here it is the evidence. So Hyun Kyun Han done study on 24 in patients randomly divided in the task-oriented training group and conventional group for 4 weeks. The task-oriented program mainly focused on the capabilities of the independent walking. They evaluated variables like GMFM, gait, and balance. And these study proved that task-oriented training after UML lesion can improve GMFM, gait, and balance. Next is the Chiang Soon Song done study on 12 children with spastic cerebral palsy children and found that the task oriented approach to treatment of the affected arm improves the functional activities such as manual dexterity and fine motor performance, as well as basic daily activities of the patients with spastic hemiplegia due to cerebral palsy. That means if you are working on the task oriented approach, so your task is that like if you want to improve the balance on the standing, so just you have to focus on the standing balance. So you have to do all these activities, sit to stand, you can doing that. Then you can give the back supported standing. In the back supported standing, you can do the side reaching. Then you can give the diagonal reaching, you can give the ball catch and throw, you can give the kicking exercise. All these activities you can do on focus on the standing only. Then and then you can get the independent standing. So it is a very important task for the cerebral palsy children, task oriented approach. Next is the hippotherapy. There are two types of the therapy on horse: therapeutic riding, it is a horseback riding therapy, and hippotherapy. Therapeutic riding is in a small group carried out by a specially trained instructor and maybe together with the physiotherapist. Hippotherapy is one to one carried out by physiotherapist giving a child various exercise on the horse. So you can see here that is a various first it is the horseback riding training, horseback riding, that is a riding on the horse. Here it is again horseback riding. Here it is the hippotherapy. So on the horse you have to give the various activities. You can give, that is a reaching activities on the horse. Here you can give the reaching activities on the horse. So because of this horse therapy you can get the proprioception activation as well as there is a vestibular stimulation also can be occur through this hippotherapy. So, a review of 11 quantitative studies by Starba in 2007 of horseback riding and hippotherapy suggests that both riding and methods are individually efficacious. There is a benefit for sensory motor experiences, rhythm, motor functions can be improved. There is a mobilization of the pelvis, lumbar spine, hip abduction with improvement of the sitting posture. However, the effect on impairment is inclusive as sample size were very small. 98% of the children had spastic cerebral palsy and few follow-up measures. Snyder et al. 2007 in their review on a horseback riding feel that these activities are family oriented in a natural environment and refers to the conceptual frameworks. They also suggest that favorable physical effects in a child, such as some symmetry in a trunk and hips. So it is a symmetry can be improved for the trunk and hips. So because of this, trunk control can be improved through the hippotherapy. So ultimately that is a sitting can be improved independently. Next is the hydrotherapy. So exercise in the water is a hydrotherapy which differs from the swimming therapy. Both are recommended for health reasons, physical fitness and family participation. Both can be carried out in the groups for social stimulation and peer encouragement. Both need to have a suitable and safe pool environment. So one of the studies there, Kelly and Dere 2005 suggested that hydrotherapy focuses on the strengthening and passive range of motion and stretching. Movements in water eliminate problems of the postural control and balance and reducing the risk of the joint loading. So you can see here these all are hydrotherapy that was given to the children. So these all are hydrotherapy. Here it is the robot therapy. So you can see it is the robot therapy. So through the robot therapy there is a socialization is improved, and also sometimes the child can learn through this robot therapy. Sometimes through the robot therapy there is a speech can be improved. Through the robot therapy sometimes you can say that child that the robot is standing, so please stand up. So that is a motor activities can be also you can initiate the motor activity. Here there is a fine motor grip can be activated. So if you are telling that touch the robot hand, so child is doing this activity, so reaching can be improved through this. So that is reaching and grasping everything, so fine motor activity you can improve this. So robot therapy is a very effective therapy for a child in the specifically in the cerebral palsy children. It is a suit therapy. So if patient's control is not there properly, so you can advise the suit therapy. And in this, after wearing this suit therapy, this is the suit therapy. Every in the every image that is a suit therapy is wearing, but it is the only suit therapy suit is there. So after wearing this suit therapy, you can do the physiotherapy. So it is a very effective giving after the suit therapy effect is there. Any questions? Anyone having any questions?
Excuse me, sir. Nikita ma'am,
Yes, ma'am.
I guess there is no query, and it was very explanatory and too much concepts was there. Uh, Thank you so much from your side, and we'll end it over here.
Okay. Thank you so much, ma'am.